Good morning, everybody. I welcome you all for this 12th PG land round. As we all know, this is a very common topic for all the residents in day-to-day working life. On the good transfusion practices, we've already had part 1, today we have part 2. And for this session today, we have our chairperson, Dr. Jaya Chaudhary. She is the professor and head in gynae department, and Dr. Priyamvada, she is professor and head in critical care medicine. We have our moderator, Dr. Shweta Sharma, professor in department of transfusion medicine. So I hand over the session to her for subsequent.
Good morning, all respected faculties and my dear colleagues. My department is fortunate enough that we got the opportunity to present our department in 2 parts. In round 1, we have completed about the how to take the consent, how to send the requisition, what are the criteria for the donations, and what are the types of transfusion reactions. So today we will be covering with different types of transfusion reactions, IHaemovigilance, massive transfusion protocols, and the special procedures related to the transfusion therapy. To summarize the previous PGCR, I would like to invite Dr. Just to summarize, last PGCR we had discussed about who can donate, who cannot donate, what are the different blood components, how are these blood components stored, what are the indications of these blood components, how to fill a requisition form, how the sample should be collected and labeled, how we do the administration of the different blood products, what is to be monitored, what is to be documented, and in case of an adverse transfusion reaction, what is to be done. I would now like to invite Dr. Somya Sharma, first year resident in the Department of IHBT, to please come up and take this presentation further. Today he will be discussing on different types of blood transfusion reactions.
Good morning, respected dignitaries. Myself, Dr. Somya Sharma, first year resident of the Department of IHBT, and I will be speaking on different types of blood transfusion reactions. Any adverse events associated with the transfusion of whole blood or one of its component. These may range in severity from minor to even fatal conditions. A reaction may be difficult to diagnose as it can present with non-specific, often overlapping symptoms. Inappropriate decisions to transfuse put patient at unnecessary risk of transfusion errors, reactions, and transfusion-transmitted infection. So we should always avoid unnecessary transfusions. These reactions can be classified according to its time interval into acute and delayed. Acute reactions in which signs and symptoms occur within 24 hours of the transfusion, and delayed in which the signs and symptoms occur after 24 hours to 28 days. These can be also classified according to its pathophysiology into infectious, non-infectious, immune and non-immune. Acute transfusion reactions which are associated with fevers are acute hemolytic transfusion reactions, febrile non-hemolytic transfusion reactions, transfusion-associated sepsis. Allergic reactions can be mild, and its severe form is anaphylactic reactions in which multiple body systems are involved. Pulmonary involvement is seen in transfusion-related acute lung injury and transfusion-associated circulatory overload. The first one, we have the acute hemolytic transfusion reactions in which we see fever, chills, anxiety, hemoglobinuria, hypotension, back pain, and DIC. Its diagnosis includes performing direct antiglobulin test, which is positive in this case, and further tests to detect hemolysis like lactase dehydrogenase, haptoglobin, and bilirubin. Management is keeping the urine output of more than 1 ml per kg per hour with fluids and IV diuretics, and for pain, giving analgesics. Second one, we have the febrile non-hemolytic transfusion reactions in which we see fever, chills, rigors, headache, and vomiting. Its diagnosis is ruling out hemolysis and bacterial contamination of the blood unit. Management is leukodepleted products and giving antibiotic medications. So whenever we are suspecting any kind of transfusion reaction, we should first immediately stop the reaction and maintain the IV access. Then we have the anaphylaxis reactions in which we see hypotension, urticaria, bronchospasm, abdominal pain. Diagnosis is checking for IgA and haptoglobin concentration. Management for IgA absolute deficient patient, we should always provide IgA deficient blood components. Then we have the pulmonary involvement, TRALI, transfusion-related acute lung injury, in which we see severe hypoxemia, respiratory failure, hypertension, fever, and bilateral pulmonary edema. Diagnosis is ruling out hemolysis, and in chest X-ray we see cardiogenic pulmonary edema, and testing donor for human leukocyte antigen and human neutrophilic antigen antibodies. Management is giving supportive care until recovery. We should stop the transfusion. For anaphylaxis, we should start antihistamines, and probably we should give respiratory support to the patient. Then we have the acute non-hemolytic transfusion reaction, which is due to physical fluctuation on the blood product, in which we see hemoglobinuria, hemoglobinuria. Its diagnosis is testing blood units for hemolysis, and management includes following standard operating procedures for equipment operation. Then we have the TACO, transfusion-associated circulatory overload, in which we see cough, hypertension, tachycardia, dyspnea, and orthopnea. In chest X-ray, we see bilateral pulmonary edema, and then we have the increased BNP, that is brain natriuretic peptides. Management includes upright posture, oxygen support, IV diuretics, and phlebotomy in severe cases. Then we have transfusion-associated sepsis, in which we see fever, chills, hypertension. Diagnosis is culture of the blood bag and culture of the patient post-transfusion blood samples to rule out hemolysis. Management is giving broad spectrum antibiotics. Then we have the delayed transfusion reactions into immunologic and non-immunologic. In immunologic, we have hemolytic transfusion-associated graft versus host disease, post-transfusion purpura, and in non-immunologic, we have iron overload. The first one in the delayed is the delayed hemolytic transfusion reactions, in which we see fever, decrease in hemoglobin count, and mild jaundice. Diagnosis is doing antibody screening and performing direct antiglobulin test. Management is identifying newly formed antibodies and transfusing patient with the compatible PRBC unit as required. Then we have the transfusion-associated graft versus host disease, in which we see erythroderma, vomiting, diarrhea, pancytopenia, and fever. Its diagnosis is skin biopsy, in which we see chronic inflammatory changes at the junction of epidermis and dermis, and the keratinocytes goes into apoptosis and then surrounded by large number of lymphocytes. Then its management includes giving immunosuppressant drugs and irradiating the cellular blood components. Then we have the post-transfusion purpura, in which we see purpura, fall in platelet count, bleeding. Its diagnosis is platelet antibody screening of the donor, and management includes giving intravenous immunoglobulins and plasmapheresis. The last we have the iron overload, which is seen in patients having multiple transfusions. Its clinical presentation is cirrhosis and cardiomyopathy. Diagnosis include doing serum ferritin levels, liver enzymes, and endocrine function tests. Management is giving prophylactic use of the iron chelating agents. To sum up, we should first stop the transfusion, give this symptomatic management, and then report the reaction to the blood center immediately. Thank you. Now I would like to invite Dr. Hrishikesh Sharma from the Department of Pathology, and he will be speaking on hemoglobin.
Two questions. You said antihistaminics. Which antihistaminic? How much? And is there any role of steroids in any of these reactions?
Yes, sir. Antihistaminics we are giving promethazine and profenadine and malate. And sir, in severe cases which are not responding to antihistamines, then we give corticosteroids in this anaphylaxis reaction in severe cases.
And second question is that when you say delayed presentations, how much delay? Is it within the hospital stay or can it happen after the patient has gone?
Sir, it is 24 hours to 28 days. It can happen after the hospital discharge also, sir.
How common is this skin?
Transfusion-associated graft versus host disease.
Yeah, because at least I don't remember that any of the transfusion medicine specialists advise
So
the
it's
skin biopsy in any of our.
0.03%, sir. Very rare. Very rare, sir.
Thank you, Dr. Somya. Good morning, I'm Writer Chairperson, sir, faculty members, dignitaries, and my dear colleagues. I am presenting the hemovigilance part, that is the how to report adverse reactions. It is It is a continuous process of data collection and analysis of adverse reactions in order to investigate their cause, outcome, and to prevent their occurrence. It is firstly the identification of problem, and then we investigate it, and then report it, and the problem is analyzed. Hemovigilance program was launched on 10th December 2012 by NIB in collaboration with Ministry of Health and Family Welfare, Government of India, and 90 medical colleges. Reporting of adverse reactions with respect to blood transfusion in the patient was launched on 10th December 2012. And reporting of adverse reactions with association with blood donations was launched on 14th June 2015 on World Blood Donor Day at Kolkata. The main objectives of the program are to monitor the transfusion reactions, monitor donor reactions, create awareness amongst the healthcare professionals, generate evidence-based recommendations, advise CDSCO for safety-related regulatory decisions, communicate findings to all key stakeholders, and create national international linkages. This is the organizational structure in which the nodal officers are come under blood centers and the national coordinating centers which come under National Institute of Biologicals, and all the stakeholders in blood transfusion services comes under Ministry of Health and Family Welfare, that is CDSCO. For the safety, in our institute we have the HTC and the meeting is done quarterly. The main objective of HTC is the safety of the patient as well as the donor in terms of transfusion. HTC works by identifying the problem, proper documentation, and what corrective actions are needed to outcome. Regulatory monitoring is done and it is checked whether the corrective actions are implemented or not. It is mandatory to check all the identifying information and document before transfusion of any blood component. It is also necessary to record vital signs of recipient before, during, and after the transfusion. While investigating ATR, both the clinical evaluation and laboratory workup are important to correctly diagnose the cause of ATR. Then the protocols. Take immediate note and inform the blood center and complete the transfusion reaction form, that is, the type of reaction, time of starting of transfusion, time of occurrence of reaction, unit number transfused, volume transfused, vitals before and during reaction, and signs and symptoms. This is the case for form of our Hemovigilance Program of India. And the CME is organized by NIB at our institute in 2019. And these are the participation certificates of Hemovigilance Program of India, and we got enrolled in 2016. Adverse transfusion reactions reported at our institute are 217, and adverse donor reactions are 271. Now I want to call upon Dr. Aparajita Pandey for massive transfusion protocol.
Good morning, everyone, dignitaries, faculty members, and my colleagues. My name is Dr. Aparajita. I'll be talking about massive transfusion protocol. So when do we call it a massive transfusion protocol? When we have 8 to 10 PRBC units transfused over 24 hours, 4 to 5 PRBC units transfused within 1 hour, or replacing more than 1 blood volume in 24 hours or more than 50% of the blood volume in 4 hours. What is the goal of the therapy? Goal is the early resuscitation with recognition of blood loss, activation of massive blood transfusion protocol, maintenance of tissue perfusion, oxygenation by restoration of blood volume and hemoglobin, cessation of bleeding by several methods including early surgical or radiological interventions with judicious use of blood component or to correct the coagulopathy. Keys of massive, 7 keys of massive hemorrhage protocol. First is the trigger plan, second is the team management, then the use of tranexamic acid, hourly tests, transfusion to the target, temperature management, and termination of the probe. What is to monitor during massive transfusion? Temperature of the patient. Hemoglobin should not be used alone as a transfusion trigger. It should be interpreted with hemodynamic status, organ and tissue perfusion. Ionized calcium range should be more than 1.1 millimole per liter. Acid-base status, pH should be managed. Base axis of less than -6 or lactate level of less than 4 millimole per liter. Platelet transfusion more than equal to 50,000. PT-APTT of more than 1.5 times of normal value, and fibrinogen. Role of assays. These are the point of care tests available to monitor the coagulation status in a patient. It can be used to guide appropriate transfusion therapy in a patient requiring blood transfusion by localizing the defect in the coagulation. This is a diagram of thromboelastography and rotational thromboelastography. I'll be talking in detail in the next slide. Now, these are the parameters of thromboelastography and rotational thromboelastography. I'll be calling it TEG and ROTEM. We basically measure clotting time, clot kinetics, clot strength, and clot stability. Now, clotting time relates to the concentration of soluble clotting factors in the plasma and the period of initial fibrin formation. The normal time is 5 to 10 minutes. If there is any abnormality in the factor, that is increase in R value, then the treatment will be fresh frozen plasma. K value or clot formation time. The normal time is 1 to 5 minutes. If there is any abnormality, there is increase in clotting factor value or decrease in fibrinogen formation, then we can transfuse cryoprecipitate and fibrinogen. Alpha angle refers to the rate of clot formation. It reflects the rate of fibrin buildup and cross-linking. Now, if alpha angle is more than, the normal angle is 45 to 75 degree. If there is decrease in alpha angle, this means there is decrease in fibrinogen factor. So again, the treatment will be transfusion of cryoprecipitate and fibrinogen. MA refers to the maximum amplitude or maximum clot formation. It is a clot strength. It represents the ultimate strength of the clot, which is platelets and fibrin. Maximum dynamic properties of fibrin and platelets bonding via GP2 or 3A receptors. So the normal value is 50 to 75 mm. Any decrease in the value leads to decrease in platelet count. So the treatment for this will be platelets transfusion. Now, clot stability relates to clot stability and lysis. It measures the rate of amplitude and reduction from maximum amplitude at 30 minutes. These are the common finding of TEG and ROTEM that we see. The first one is normal. I would like you to see the last point during disseminated intravascular coagulation, which is very commonly seen in our setup. So we see this kind of graph in thromboelastography. The stage 1 is hypercoagulable state with secondary fibrinolysis, and the stage 2 is hypercoagulable state. Now, massive transfusion in trauma. Adult trauma patients with or at risk of massive hemorrhage should initially be transfused empirically with a 1:1:1 ratio of plasma, red cells and platelets. These patients with or at risk of major hemorrhage should be given tranexamic acid as soon as possible after the injury. Obstetric patient, blood component therapy should be same as in non-pregnant patients, except that fibrinogen supplementations with cryoprecipitate should be considered at fibrinogen levels that are less than 2 grams per deciliter. Tranexamic acid may also be considered postpartum. Special situations. Unconscious patients, anesthetized patients. These patients pose peculiar problems during sample correction and blood ordering. If at any point patient name cannot be assigned to blood request form and blood sample, unknown with unique hospital registration number, it can be used rather than mentioning no name. When more than one such patients are present, they can be labeled as unknown 1, unknown 2 or so on. Now I would like to call upon Dr. Nisha Raj for special procedures in transfusion therapy. Thank you.
Thank you so much, Dr. Aparajita, and a very warm welcome to everyone once again. I, Dr. Nisha Raj, first year resident in the Department of IHBT, will be walking you through the special procedures done at our center. So the special procedures that are done at our blood center are based on the principle of apheresis. So what is apheresis? Apheresis is derived from the Greek word apheresis, which means taking away. It is a process in which the whole blood of a person is passed through an apparatus that separates out one particular constituent and returns the remainder to the circulation. So what is this principle? The patient or the donor's whole blood is collected. The cells from the blood are separated by an apheresis machine. The needed cells are collected into a sterile bag, and the unused components of the blood are returned to the patient or the donor. How is this possible? Well, each cellular component of the blood has a different specific gravity, and based on the specific gravity, when the blood is passed into the centrifuge of the machine, they form layers. So the heavier ones will settle down and the lighter ones form the top layer. That's how the cell separation is possible. In the picture on the right, you can see how the heavier erythrocytes have settled down and the lighter plasma forms the top layer. So I'll be enumerating the different special procedures that we have. The first one being single donor platelet pheresis, which is the collection of platelets through the apheresis method. Single donor plasma pheresis, or collection of plasma through the apheresis method. Therapeutic plasma exchange, that is plasma removed and replaced with fresh frozen plasma or albumin to the patient. Leukapheresis for collection of granulocyte. The granulocyte collection is done after the donor is stimulated with the granulocyte stimulating factor. Leukapheresis for collection of mononuclear cells and lymphocytes. Peripheral blood stem cell collection, which is an effective approach to obtain a hematopoietic graft for stem cell transplantation. Erythrocytopheresis, where RBCs are removed from whole blood during the apheresis procedure and replaced by a crystalloid or a colloid solution. So any special procedure asks for dedicated special machinery as well. So the machines that we have available are displayed in the picture. The first one is a compact machine from the company Hrishikesh Sharma. This is a multi-purpose machine and it can be used for the purpose of peripheral stem cell collection, therapeutic plasma exchange, double cascade plasma pheresis, granulocyte collection and mononuclear cell collection. The only difference comes that there are separate kits available for the different procedures. The other two machines, that is the Trima and Emico, is used for the purpose of single donor platelet collection. Before a special procedure, there are some mandatory requirements. The first one is a justifiable indication. Next comes a duly filled request form. Then comes our donor detail form and consent form. We also require the blood grouping, antibody screening, and transfusion transmitted infection screening for both the donor and the patient. The first procedure is single donor platelet pheresis, or commonly called as a single donor platelet. You can appreciate in the picture the procedure going on. Here the blood is drawn from the patient. The blood is separated into components by a centrifuge which is present in the machine. The needed component, that is the platelet, suspended in the plasma, are collected in the sterile bags. You can see the sterile bags hanging. And the unused component are returned to the donor. We have completed 6,409 cases till now. These cases were mainly for transplant patients, malignancies, and patients suffering from TB. This year, in the last 6 months, we have completed approximately 650 cases. Our next procedure is leukapheresis for granulocyte collection. This is used for patients with severe neutropenia, that is the absolute neutrophil count below 500. Once the granulocytes are collected, they are stored at room temperature for only 24 hours and they should be transfused only after irradiation. Irradiation is important because transfusion associated graft versus host disease is avoided. The donor should be ABO compatible. We have completed 65 cases till now, and today also one case is scheduled. Now, once the donor is selected, he has to undergo the pre-medication protocol. This is to mobilize the WBCs into the donor's circulation. So, the procedure starts 15 to 18 hours before the planned harvest. The donor is administered tab pantoprazole, tab prednisolone, which is given at 1 mg per kg body weight. And thereafter, he is given injection filgrastim, 300 micrograms subcutaneously. The donor is called the next day. A complete blood count is done. 300 micrograms subcutaneously.
What is
So this is the granulocyte colony stimulating factor. The next day we do a complete blood count. In the complete blood count, we see the number of WPCs to identify how much the WPC count has increased. Thereafter that, injection dexamethasone 8 mg is administered, and then after 1 hour we plan the harvest. Our next procedure is peripheral blood stem cell collection. Stem cell transplant can be of two types. That is, one is autologous transplant and the other is an allogenic transplant. Autologous transplant involves when the patient himself donates his own stem cells for future use, and in an allogenic transplant, a healthy donor donates his stem cells for the patient. So where all is this used? So aplastic anemia, Hodgkin's lymphoma, multiple myeloma, in such diseases we are using. The donor should be abiocompatible and HLA matched. We have completed 61 cases till now, out of which 42 were autologous and 19 were allogenic. Majority of the autologous cases were for multiple myeloma followed by Hodgkin's lymphoma, and the majority of allogenic harvests that we had done were for the purpose of for patients suffering with aplastic anemia. How does the stem cell transplant happen? So first of all, either the patient or the donor receives a pre-treatment to release the hematopoietic stem cells from the bone marrow into the circulation. Thereafter, the collection happens. Once the peripheral blood stem cells are harvested, they are frozen. We cryopreserve our products here. Thereafter, when the transplant is planned, the product is thawed and is infused to the patient. After the patient receives the transplant, he undergoes the supportive treatment to help the bone marrow regrow. Role of CD34. See, the CD34 is a cell surface marker which is used to measure the hematopoietic progenitor cells or hematopoietic stem cells. So the CD34 count is done to see the number of hematopoietic stem cells that are in the circulation and whether we have achieved the cutoff or not. So that's how we can plan the harvest. It is done by the process of flow cytometry, and this is a picture of the flow cytometer that we have in our blood center. Our next procedure is therapeutic plasma exchange. It involves the removal of patient plasma with return of the remaining blood constituents to the patient, and the removed plasma is replaced with a replacement fluid. The replacement fluid can be albumin or fresh frozen plasma depending on the disease and the condition of the patient. The American Society of Apheresis has indicated 91 diseases which have 166 indications which have been divided into 4 categories and 2 grades. This is a glimpse of their classification. So how does this therapeutic plasma exchange work? So basically, the blood is collected from the patient. It is mixed with an anticoagulant, passed into the centrifuge of the machine. The patient's plasma gets collected and discarded, and the replacement fluid is added to the remaining blood and it is transfused back to the patient. We have completed about 401 cases till now. Majority of these cases were for patients suffering with acute liver failure, post-liver transplant patients, patients suffering from Guillain-Barré syndrome, post-Pasteur syndrome. Our next procedure is double cascade plasma exchange. Double filtration or double cascade plasmapheresis is a newer technique in which plasma is not entirely removed, but only the antibodies are removed using specialized filters. It is mainly used in abioincompatible organ transplant where desired titers are obtained with the help of this double cascade plasmapheresis. You can appreciate in this picture the filter that is used. We are using the Evaflux filter. And in the schematic diagram, we can see how the blood is collected from the patient. It is sent into a blood cell separator or the centrifuge. Then the plasma is collected and passed into the filter. And then after that, the filtered plasma and the remaining blood is again transfused back to the patient. Coming to our last procedure today, this is therapeutic phlebotomy. Therapeutic phlebotomy is when blood is drawn to treat a disease. So therapeutic phlebotomy is safe and easy, and it may be done weekly, monthly, or less often depending on the condition of the patient. The indications include polycythemia vera, hemochromatosis, and maybe post-kidney transplant. And to specify, the blood that is collected from such patients is not used for any therapeutic use. It is not transfused to anyone. And that's also thank you. I would now like to invite Dr. Somya Sharma, Professor, Department of IHBT, for our take-home message.
You said pantoprazole is given. Why?
So, because we are taking
So the primary drug is steroid. To cover the side effect of that, you give pantoprazole. So order of mention should have been prednisolone with pantoprazole. Okay, pantoprazole is not the primary drug. What are the conditions where lymphocytes or monocytes will have to be given to a patient? Because you said you can separate lymphocytes and monocytes also.
So we do leukapheresis when
Let her first. If she can't, then you take over.
So to what I know, patients suffering with bone marrow disorders, they like aplastic anemia.
But then we will have everything deficient. Why? Which conditions specifically you need lymphocytes and monocytes? Hemoglobin, platelet, neutrophil, we all know. We don't know lymphocyte and monocyte.
So at present, mainly for the lymphocyte collections, for the patients, those patients when we collect their lymphocytes, those patients can go for the CAR T cell therapy. And so recently, we are doing leukapheresis for the dendritic cell vaccine program, but from the healthy donors.
You said you have done 6,000 something leukapheresis. I don't know in 1 year, in 5
No,
years.
this is from since 2018, sir.
And the best way to show your numbers is you make a bar chart, year-wise bar chart, which will show increasing numbers. That has more impact than just an absolute number. Okay. Phlebotomy. Is there today an indication for phlebotomy? Have you done any phlebotomies in last few years?
Yes.
We are doing some.
Phlebotomy? Yes, sir, we are doing. Yes.
So there are conditions which cannot be controlled by anything else except phlebotomy.
Yes, sir.
Thank you to all my presenters. As we all know that blood or any of its components cannot be manufactured. So before going for the summarization, I just want to ask each and every resident sitting over here, how many of you have donated blood in your life? The reason of asking this question is very simple, that if we have not donated the blood, we can't motivate others to donate the blood. Right?
Please, may I ask a question?
Yes, ma'am.
We are listening about synthetic blood. So can you throw some light on that?
Ma'am, at present in India, we are not into this product of synthetic. They are under the trial. Yes, ma'am, they are trying. They are trying.
Are they useful?
No, sir, ma'am, they are not using it right now.
Only
Sir, they are trying to get it done.
People
So-
are making synthetic sponsors. Sorry, trials.
So the transfusion practice lies with the following chain. It lies with the recruitment, collection, and the retention. Recruitment means the recruitment of the new donors, and the retention is very important. Many a times what happens that the donor comes and they donate once, but they don't come back. The reason being, they consider that maybe their blood will not be used properly, maybe their blood will be discarded. So retention of the donors is the very responsibility of all the blood centers. Then second chain lies with the testing, processing and issuing of the blood components, and the transfusion monitoring and the follow-up that we have covered under the Haemovigilance. Every year, 14.6 million units of blood are required in India. And as we can see this data, how many infants are born with the thalassemia and sickle cell. In our institute, we are giving thalassemia free blood to the thalassemia kids. Every 21 days, they need blood. In India, 234 million major operations, 63 million trauma-induced surgeries, 31 million cancer-related procedures, and 10 million pregnancy-related complications need the blood. So we can understand how much blood is required. But what is the strength? But just to share today through this platform, what I have realized in my journey, that the strength of any transfusion practices, or we called it as a good transfusion practices, lies with the heart and soul of the donors. If we have a good bulk of donors, we can provide the best services. But if we don't have the donors, we can't do anything. So, sir, through this platform, I request
that we should start a registry of our institute with involving all the students so that they can voluntarily enroll with the registry and we can call them whenever there is a need of SDPs to us.